I'm Councillor Alison Martin and I'm the Cabinet Member in Derby for Health and Adult Care. Thank you.
Carmel Ashby, Councillor.
Good evening, everybody. Councillor Jamie Mulhall. I represent Oakwood Ward.
Claire Johnson, Head of Quality for Maternity and Neonatal for Derby and Derbyshire ICB.
Hi everybody, my name is Beth Fletcher. I'm an Engagement Manager in the ICB.
Councillor Richard Hudson, Councillor for Chaddeston North.
Chris Weiner, Chief Medical Officer in Derby and Derbyshire ICB.
Robin Jewis, I'm Director of Public Health for Derby.
Agnes Berenchak, Screening and Immunisation Lead for NHS England Midlands.
Julia Grace, Deputy Director for Vaccination and Screening NHS England Midlands.
Good evening, Alan Reid, Consultant in Public Health.
Good evening, Sean McGill, Acting Consultant Public Health. I'm just observing.
Thank you everyone for the introductions. First on the agenda is apologies. We have apologies from Councillor Lawson and Councillor
Jamia Khan and Sarah Noble.
And Sarah Noble. Any other apologies? Nope. Late items, there's no late items. Decorations of interest. Okay. Minutes of the meeting held on 28th of January 2025. Does anyone want to raise any matters on this? Can we take it as the minutes being approved? Yep. Item 5, newborn blood spots and sickle cell carrier results. Who would be doing this? Okay, thank you.
Thank you. So by way of introduction, firstly, thank you for inviting us into your meeting this evening and for providing us with the opportunity for us to explain to committee members the details surrounding the failure to notify Derbyshire families that their child was a carrier of sickle cell or unusual haemoglobin gene. We'd like to share with you this evening how this failure came to light and what actions have been taken since by both NHS England and the Integrated Care Board partners to both prevent this from happening in the future and also to share the lessons learned. Before I hand over to my colleagues to explain the further details, we would like to begin with an apology to Derbyshire community and all of the families that are affected and to say sorry that we failed to inform families in Derby and Derbyshire that their children were carriers of sickle cell or unusual haemoglobin genes. The children that are affected do not have and will not develop sickle cell disease. However, we recognise the importance of all affected children and their families having this information communicated to them at the earliest opportunity. We have since put in a robust process to make sure that this does not happen again and that affected families are informed as soon as the carrier results are available. Since the incident first came to light, we have directly written to each of the families affected, firstly to apologise for the failure to inform about their child or children being a carrier, and also to provide information to help support understanding of what being a carrier means for them and for their children, and to offer access to a healthcare professional who could explain the carrier results if parents wanted further information. I'm going to hand over to Agnes, who will explain more details, and then ICB colleagues are going to talk about the future-facing pathway, and we'll hopefully then be able to have the opportunity to get into some questions. Thank you.
Thank you. So thank you very much for inviting us to come and to talk to you about this incident. So we are sorry that we failed to inform families in Derbyshire about their children a sickle cell carrier as soon as we should have done. And we are grateful for the opportunity to come and to explain the work what we've done, how we identified individuals who were affected by this incident, what we done to contact them directly, and what processes we put in place to ensure it won't happen in the future. So in 2023, NHS England received a notification of 2 cases when parents didn't receive their sickle cell carrier result of the children timely. This was related to the newborn blood spot screening. The screening takes place when a small blood spot taken from the baby's heel and tested against 9 rare but serious health conditions. And one health condition is a sickle cell disease. So this test also identifies babies who carriers of this gene and they don't have sickle cell disease, but they pass this gene on to their children. It's worth noting that babies who had sickle cell disease were referred timely and they received the appropriate treatment. So going back to the report, so we received these 2 cases and there was a 4 months gap between the 2 cases. So we wanted to learn whether these 2 cases happened by chance or we have an issue with the carrier notification pathway. So we launched an investigation and we started with a look-back exercise. So this look-back exercise covered 5 years. And during this exercise, we asked GP practices to check their record, whether they had recorded a conversation with parents about their children's carrier result. When we get back the audit result, it shows that about 50% of cases, although this conversation may have happened, but there wasn't any written evidence in the GP records. So based on this finding, we decided to convene an incident management team, and we invited the Derby City Local Authority, Derby County Local Authority Public Health Teams, NHS, Derbyshire Integrative Care Board, and all stakeholders who participated in the newborn blood spot pathway to attend this incident management team. And the team carried out a fact-finding exercise, and this highlighted that there was a significant change to the pathway in 2012. Up to this point, there was a dedicated health professional who discussed carrier results with parents, but this post was disestablished in 2012 and wasn't replaced. So the panel decided we cannot be assured that all parents receive the result consistently. So the decision was made that families whose baby have been born since January 2012, we received a notification letter and explaining the carrier status of their children. This cohort included 839 babies. So all families received the letter. The letter included an apology, also included explanation of the gene what their baby had, and information about the incident and the patient leaflet. A helpline was also established that the parents could call. The letter was followed up by an active phone call where parents was asked whether they want to have a conversation with a health professional who can explain what being a carrier means and can answer their questions. And if they wanted to have this phone call, it was arranged. With the agreement of the Sickle Cell Society, the letter also included the Sickle Cell Society contact details, helpline, telephone helpline, and also a confidential email address. And NHS England shared their complaint line, which was included in the letter. So families were notified in July 2024. The phone calls lasted until the end of September, and the helpline was open until the end of December. In summary, so we have 839 cases altogether. 557 families took the telephone call after receiving the letter. In 276 cases, we don't have returned from, the letter didn't return, but these families didn't took the call. The incident management team made the assumption they received the letter and the information via the letter. 76 families wanted to have a conversation with a health professional, And we had 2 families, one with 2 children, that we couldn't contact. So their letter was returned, and despite all effort have been made, or was made, we couldn't find telephone number for these families. Incident management team made the conclusion that all reasonable efforts have been made, and this family is very likely to have the country. So once this letter had been sent and the phone call was made, we attended a community event at the Derby West Indian Community Association. We offered apology to the community, and we explained the reasons what could lead to this incident based on the information that we had at that time. We worked with the Sickle Cell Society throughout this incident investigation to ensure we use appropriate language, so they supported us and shared their contact details and offered their help if anybody needed this. We also updated GP records, and the GPs were kept in the loop, and they knew about the helpline. NHS England also maintained the service for newly born babies until the new advisory service was established by the ICB and launched in January. So this service provided the same offer, so the parents received a letter and also had a phone call from a professional. So we wanted to capture the learning from this incident, so we carried out a complex root cause analysis. We identified 20 factors that could lead to this incident. And based on these 20 factors, the incident management team agreed on the 8 recommendations that we made. And one recommendation was this all have been completed or what is working towards the completion. And one recommendation was to setting up a new advisory service, and this was done by the ICB and was launched in January. Over to the ICB representative. Please, if you wouldn't mind explaining what this service offers.
Thank you for that, Agnes. Yes, so as Agnes has described, this situation arose as a result of the loss of a key post in 2012, and that post was associated with feeding back this information to families. And it became clear that since 2012 we hadn't had a consistent approach to ensuring that families were made aware of sickle cell carrier status in their newborn child since that point in time when that post was lost. Derby and Derbyshire ICB apologise for that. It shouldn't have happened. Okay, it should not have happened. And we have put in place a process to try and correct that. So from 1st of January this year, we have commissioned a service from UHDB, University Hospital Derby and Burton, from our specialist haematologists who are working in that organisation. This is a service which has a service specification, has resources wrapped around it, with key performance indicators now in place to ensure that actually no family is lost to the follow-up, and that all families have the information given to them around sickle cell carrier status in their newborn child. Since January, between January and the end of March, I can report that we've had 31 families who've been through that service, and we have 87% of those families receiving the information in line with the key performance indicators that we've got. We are currently looking at the reasons why 13% of families, there seems to be a delay in terms of getting the information through to them, and we'll aim to sort of tighten up that feedback to those individuals. But we think at this point in time, it may be linked to blood spot tests not being done at the point when the child is in a hospital setting. So, but we're still looking into that. So I think the position we've got is a new service which is up and running, has been up and running since the beginning of January, and at this point in time we're monitoring the key performance indicators, but I think we're in a much better position now than we were prior to this event happening. And certainly, I think we've got stronger assurance over the kind of model that we've got today than we probably had in 2012 when we lost this service. So that's where we are today. I can also advise people that we are going to be going through two further engagement events, one in Derby City and one in Chesterfield here in the middle of May. Just mislaid the dates briefly on those, but I can look those up in a second if required, where we'll be talking with the families or potential families who've been affected and people who are interested in this subject to get further feedback on the way we're communicating, the nature of the letters, etc., that we are sending out to families and the information they receive at the point when their families are made aware of sickle cell carrier status. So I think that's where we are, Chair. Thank you.
Thank you for bringing this report to the Scrutiny Board meeting. I'm sure we've got plenty of questions, but before I open up to the floor, I would just like to ask some of my own questions. Is there any evidence that any children have suffered harm as a result of families not being notified of the carrier status? Thank you.
We haven't been informed about any harm, so we don't know anything about, or haven't been informed, and we haven't received any notification about harm.
What assurance can you give that similar communication failures are not occurring in other parts of newborn screening programme?
When you have humans involved in a pathway, you always can have errors. But we do our best, and our providers do our best to check their processes and have a thorough safety net around their processes, and they report this to us regularly. So we have this assurance via regular meeting with the providers. Obviously, we do our best, providers do our best, and we maintain this robust reporting arrangement. This is what we can say.
Another question is, how does Derbyshire screening communication failures compare with other regions? Is it just unique to Derbyshire and Derby, or is it a national issue?
I cannot comment on national issues because we cannot review the national processes. The national team was involved in the incident investigation, so they are aware of the incident findings, and we reported back these findings to the national team. They took the learning, and as a result, they amended the national guidance.
Okay, thank you. I'd like to open the questions to the floor. Has anyone got any questions? Councillor Ashby.
Thank you. Firstly, thank you very much for a very comprehensive report and for all of the detail that was in it about all of the, the deep dive that was taken to understand what had happened and what had gone wrong. And thank you also for all the detail that's been given about how the issue's been addressed and the processes that have been put in place to make sure it doesn't happen again. I think Councillor Cuss's question about whether it's happened in other areas is actually a very good question. Obviously, we know why the process fell apart in our region because of the loss of that post holder. And it almost seems like a presumption that GPs would take over the role without clear communication with them, that was the expectation. What the report doesn't bring out is that actually it's not routine for GPs to give reports from national screening. You know, all of us here as ladies know that we get our national screening reports, whether it's for cervical smears or breast screening, come from the provider of the screening. They do not come from the GP. The GP receives the report, but they just receive it for completion of the person's health records. So I think for people reading the report who may think, oh, the GPs were negligent, I was just a little bit disappointed that it didn't make clear that that was not, for the rest of national screening, GPs are not involved in giving results. So it would have been perfectly reasonable for GPs receiving these results to, unless it had been very clearly communicated that they were expected to pass on those results to the families, it would have been reasonable for them to presume they were simply receiving the results as they do for all the other national screening that happens. But it does make me wonder whether, for some reason, the conveying of results of carrier status for hemoglobinopathies isn't dealt with nationally in the same way as other national screening results. I'll leave the question with you. I'm not presuming you'll have the answer, but I think it's a question that's worth asking, because otherwise this could well be happening and replicated across the country. I would reiterate what you said. I'm sure no harm will have come to anybody, because thankfully it's only gone on for 12 years. So the carriers are still children, so are not likely to be in a position where it's going to be relevant in adulthood more than in childhood. Thank you.
Has anyone got any? Councillor Martin? Yeah, sorry.
Thank you, Chair. Thank you for... You've pretty much covered what I was going to say, what was rattling around my head. I'm just going to go into the communication. There's a lot of talk about telephone calls, letters, etc. Now, I'm at a point where I've started ignoring phone numbers that I don't recognise. Yet I do respond to text messages and emails in 2025. Are they included in the communication mix or not?
Text message wasn't sent.
Not text messages used in the communication mix now. Right, thank you.
Call.
Thank you, Chair. Yes, thank you, and thank you to the team for your report. I have met you before, obviously, when you came to Derby, when this first came to light in late 23, and it was indeed very concerning news to receive. And I know you met us at the Council House, and we talked about the way forward, and myself with a couple of my councillors who are from the African and Caribbean community, and I thank you for that. I know at the time we were very concerned that families should be communicated about this problem as soon as possible, and I believe in large part they were, but I know that took some time for various reasons, and it was a little tardy, I think, but we seem to have got there in the end. So I do, as a cabinet member, I can't speak for the community, obviously, goes without saying, but I personally do welcome the apology that you've made for this, which wasn't a consciously intentional oversight. I think people would recognise that. So the apology is welcome, and clearly the new process for informing parents is equally very welcome. I'm grateful for the Derby and Derbyshire ICB for stepping in to play a role in that, which I think is kind of reassuring, because I think there is a need for more localised NHS management, and particularly accountability, and I understand that's why you're here this evening, because you are being rendered accountable. So those things are good. Also welcome the engagement events, and I have been invited to attend the one in Derby in May, so I will be attending that. I suppose, so that's good, and we'll see whether the new process is working robustly. I know Dr. Viner has given us some feedback on that, and obviously we need that to work through in time, just to test how robust it is, and hopefully members of the community predominantly affected will also be feeding into that feedback on the new process, which I think is the crucial thing. So obviously things have moved on since 2023, and that is welcome. Forgive me, Chair, I will get some points and questions. I suppose the question to remain is that it is really concerning that it took 11 years for this to come to light. I mean, it is really, really concerning. I don't know, it's not clear to me how the learning what learning we have from this as such, in the sense that there's been a process of investigating what went wrong. But I mean, and then there's a process of trying to put this particular problem right. I'm interested to know, you know, can we be reassured that this is this learning that may have come from this is being extended to other areas, other issues, other problems, perhaps where relevant, maybe for other conditions. I think that the problem came about apparently mainly because of the loss of a member of staff. Well, through no fault of anybody's own locally, the NHS is currently going through a major management reorganisation and restructuring through loss of management staff, and that may or may not be the right thing, but it is happening. So I think we need that learning to understand how we can avoid such oversight happening again in the future. And I do appreciate that not all that is within your remit. You're not sitting there running the NHS nationally, but these are areas of concern for myself and for the community. And I suppose crucially, the issue that kind of isn't expressed here but does speak itself very implicitly is this issue of the unequal treatment and inequality and injustice and health injustice that this scenario kind of manifests. So I appreciate that there were various factors going on throughout the system which caused this to come about, but I still think that, I mean, it would be interesting to know whether you feel this level of error, if you want to call it that, is restricted to this sickle cell hemoglobinopathy, or whether other conditions were parents given the results. Is it just this particular one where we got the error? Is there a comparison where we can say, well, this didn't happen here, but it did happen there, you know? And I think that's important in terms of understanding the way the NHS implicitly engages with different communities. So one of the things I don't find convincing at all, if I may say, in relation to the reasons you've given for the identifying why this happened, is lack of understanding throughout the system about the importance to the community of knowing their carrier status early. I don't find that convincing at all, if I may say. First of all, this word early at the end suggests that there may have been a process where there was an intention to inform people later. Well, there clearly wasn't. This was a failed process. It wasn't a deferred process. It wasn't a process that might have happened at another time. And as Councillor Ashby has already indicated, it was assumed that a process would happen that is completely extraordinary and not normal practice anyway. So I think that what we're seeing is some complacency, to say the least, within the system. I don't know why anybody in the system would assume that the community affected wouldn't want to know about this carrier status. And as somebody who had to be persuaded when my son was born that he did actually need, that he was best when he'd just been born, to have one of these things stuck into his heel, I'd also want to say, well, you know, if you want the community and people, members of the public, to be part of this process of testing, then I would assume that it should be implicit within it that there is an assumption that if there are any problems, it's automatically assumed that the community or the individuals affected would want to know the results. So I'm afraid that particular phrase I find very frustrating. And the reason I'm raising this, and I am being a little critical, is because it's so important that we understand the cultures of the NHS, the assumptions, the processes. Otherwise, I don't think we can have the confidence that this kind of scenario won't happen and again. So, and also I share my fellow councillors' concerns about whether we do really have the confidence of knowing whether this is a Derby and Derbyshire issue or whether it affects other sickle cell carriers in other parts of the country. So, sorry, you've been very patient, Chair, thank you. So those are my comments. There were some questions embedded within it, and I hope that I can get some responses. Thank you.
Sorry, would you like to answer some of them questions, what was given?
So first of all, thank you very much for your comments. It's very helpful, and I think it's quite complex, and you raised a lot of issues or concerns. I think I'm not sure whether I'm the right person to answer national questions. As I mentioned, we involved the national team, so they took the learning, they changed the national guidance as a result to ensure it's more robust, will be robust enough in the future. But if you think it would be helpful to have a separate conversation, I'm more than happy to go through your concerns and how we can address these concerns by one, because there was a few points raised, and I think we need to consider them carefully and in the future.
I was just gonna add to that. Thank you, Agnes. We don't disagree with you. You know, all of the points that you've made are completely valid. We absolutely, as we've said, you know, apologise for what's happened. As you can see from the report, the root cause analysis has been through our incident management team and thoroughly scrutinised by the incident management team to make sure that colleagues are content that we've identified the root causes and indeed the actions that need to follow. And I think that, you know, we agree with you, you know, that the importance, it's absolutely clear to me, having been involved in this incident, and I know from my colleagues, speak for my colleagues, that actually, you know, the impact that this has had on the community, and going to the community event, we saw that firsthand. So we absolutely appreciate that, you know, and personally learnt a lot from that experience. So I think the importance of the community knowing their carrier status early is obviously absolutely critical, and we apologise that didn't happen, but completely understand the importance of that happening going forward.
Councillor Ashby.
Thank you. Thank you. Thank you for that. I think probably many of us in the room are still left with the question whether it isn't possible that this problem actually has gone undetected and is going on undetected across the country, because obviously it seems to me, but please correct me if I'm wrong, that the conveying of the results of sickle cell carrier is dealt with differently to the conveying of the other results from the spot test. The other 9 really, conditions, you know, so whether if you actually have sickle cell disease or any of the other conditions that are tested for, there's obviously a process for conveying those results to the parents. But for some reason, sickle cell carrier doesn't seem to have a national programme for, or national process for giving that result. Are there national processes for all the other results? Is sickle cell carrier a one-off and different to all the rest, or where, and if it is different to all the rest, what is NHS England going to do to make sure that all the regions in the country are making sure they don't have the same problem?
I'm just going to come back on the first part of your question, I think. So what we do know is that national colleagues, when this issue came to light, asked all regions to do their own level of assurance in terms of confirming what their pathway is for communication. So we know that national colleagues did ask for that assurance across the other regions. I don't think I'm equipped to answer the second part of your question, if I'm being really honest, and it's one that we might need to take away and talk to national colleagues about in terms of the national processes for informing results across all screening programmes. So I think that's probably one that I would want to take away if you're comfortable with that. Thank you.
Thank you. Yeah, I think it's it'd be wise if you could take it away and get back to us if it is a national issue. I think that would be important. And just going back to Councillor Hudson's point where we got 234 people that didn't answer a call after 4 attempts. And I think it's right to ask for other methods of communication as in like SMS, because I get phone calls as well where if I don't recognise the number, I might not answer it, it might be spam. Have there been voicemails being left as well? And that's another question. So yeah, maybe explore other ways of communicating with these people. Has anyone else got any questions? Yeah, Councillor Hudson.
Right, there's this comparison with other areas obviously coming through. Are there any case studies of a similar scenario to this happening elsewhere in, say, the last 15 years, and how does it compare to what actually happened here? This board at a future meeting, if there is an example case study from elsewhere, might want to actually see it.
I'm not aware of any case studies.
Thank you. I just wanted to come back on the use of the word harm, and I think colleagues, when they've been using the word harm, have been specifically talking about physical harm to children and young people. And I just want to acknowledge that actually there is a significant amount of harm for the families and the community with not being given that information, but just noting that no harm's been reported is about any physical impacts on those children. We don't want to diminish the other impacts of harm on both on the families and on the communities that have been affected by this.
Yep, Councillor Martin.
And I think if I may just stress one of my points, if that's all right, if you'll bear with me, thank you. So, because you did sort of respond to a couple of them, but I think Councillor Ashby raised this, and I don't think it's been addressed particularly, is that we know there's been this problem in relation to sickle cell carrier status. Not talking about a comparison nationally now, but looking at the local situation. Is this the only condition that was subject to non-reporting to parents in the last 14 years, or were all of the conditions reported to parents? Thank you.
Yes, positive conditions have been reported to parents. So when a baby has a positive condition, it was reported to parents, and the baby was referred to a specialist services.
So if they had any, so is this the only condition, if you like, that is this the only status or condition, if you like, that wasn't reported to parents?
Yes, as far as we know, this situation is isolated to carrier status only.
Any further questions?
Thank you, Chair. It's not a question, but I wanted to take the opportunity just to make people aware of the dates of these engagement events that we've got coming up. So on the 14th of May at the West Indian Community Centre in Derby City, we'll be having an engagement event, starts at 6 p.m. And then the following day, again at 6 p.m, another engagement event up in Chesterfield area at the Arkwright Centre, Chair. So I just wanted to take the opportunity to let the committee know about those events and to publicise those events.
Thank you. So moving on to the report, section 2.1 and 2.2, to consider the newborn blood spot and sickle cell carrier results report, and to make any further comments or recommendation following discussion on the report received. Does anyone want to put any recommendation forward? I was going to put one forward, which was I think we should add this to be reviewed again, especially with the new processes in place and the questions what we asked today, if they can go away and bring that back, and maybe we can have a look at the progress of the new processes in place and the outcome of parents who haven't been contacted. So I would like to bring this back to the board if people are happy with that. Is anyone against? Okay. Thank you. Okay, moving on to item 6. Sorry, do I need a seconder for that? Recommendation? No, it's fine. Okay. But it's been a while since I chaired a meeting. Item 6, maternity service in Derbyshire, April 2024 to February 2025.
Thank you.
Claire Johnson. Thank you.
Thank you, Chair. So the paper that has been submitted contains information around UHDB and Chesterfield Royal Hospital maternity and neonatal services. I'm going to pick out probably the bits around UHDB just to highlight because that's more pertinent to the city. We presented last time in May 2023 to this committee, and at that point UHDB did have significant problems around their maternity and neonatal services. They voluntarily entered the Maternity Safety and Support Programme in March of that year, and in November of that year they were issued with a rated inadequate by CQC for safe and well-led maternity services. Since then, I think there have been quite significant improvements made. At that point, the workforce gap was around 10 to 12%. The stillbirth and neonatal death rates were both above national average, and there were definitely gaps in senior leadership due to regular changes of the senior managers and the deputy, director of midwifery. Currently, the stillbirth and neonatal death rates are below national average and have been for a year consistently. There's been significant investment in senior leadership, and there's more stability within that team now, and more support for the director of midwifery. The workforce has improved to now having a 4% midwifery gap, a 6% turnover rate and a 5.5% retention rate. Saving Babies' Lives Care Bundle, which is contains 6 elements which are recommended for trusts to implement to improve safety for babies and improve their outcomes. Compliance has improved from 33 to 77%, which is a significant improvement. And this month, in fact, they've just had another assessment, which isn't in the report, and they've now moved up to 83%. So there is continual improvement being seen. For the maternity incentive scheme for trusts, which again have 10 safety actions, this year, for year 6, UHDB reported compliance with 7 out of 10, when previously it was 2 out of 10 safety actions. So recognising there's still work to be done, but again, it is an improvement. Chesterfield, just on that point, did meet the 10 safety actions. There's also been investment in supporting families from ethnic minorities, particularly the South Asian community, because it was noted through an extended perinatal review that was done in 23-24, that they were experiencing worse outcomes at that point. So they have invested in supporting those families. And there's been improved data collection, which assists us in getting the assurance we need to make sure that they're meeting the targets that they need to meet. There's still work to be done, as we say. They're not there yet, but they're definitely moving in the right direction. They've just applied to have 6 of the 8 Section 31 recommendations removed, and they're working towards removal of the remaining 2, and also they're working towards meeting the conditions through the Section 29A, which was also issued in November 2023. Work still needs to be done around investing in a perinatal pelvic health service, which is a national recommendation, and also in continuity of carer teams, particularly to support those from most deprived areas and those from ethnic minority communities. Overall, we are continuing to work with the Trust to improve their quality of the service, and Derby and Derbyshire ICB do maintain oversight to get the assurance required on the services in Derbyshire. Any questions?
Thank you for the report. I'd like to open the question to anyone on the floor, please. Any questions? Councillor Ashby.
Sorry, I was saying I have a few, but if others needed to go first. Firstly, on page 6, 2.91, the report says Derby had a similar, it's stated that Chesterfield was 8th in the country for something, and Derby was similar to 2023. Well, unless you were here in 2023, and I wasn't on this committee at this time in 2023, I have no idea where Derby was in 2023. So it's a really unhelpful thing to put in a report. And there were a few instances. I wrote that one down at the end because there'd been one earlier on, and I thought, just give me the information. I'm reading this report. I'm giving you the respect that I believe you deserve because you've written it, and I think I should read it all. But I'd like to understand it all. So I think being more specific would be really helpful. Fetal monitoring training is mentioned. But surely that's a basic midwifery training. So I don't understand why it needs to have special input unless it's for people who are not trained midwives or not trained doctors. I was a bit shocked that that was needed, to be honest, unless it was for HCAs, in which case one would be inclined to question the degree of responsibility that's being left with them. And again, in, I think, 2.932, it said that the university hospitals of Derby and Burton had brought in signposting for the two sites. And I wondered whether that meant that the more complex cases were signposted to the Royal Derby rather than to Burton, or what. Again, it just wasn't entirely clear what the report meant by that. And I also wondered what this new open door policy for people whose first language wasn't English meant. So there were a few things that, having read the report, and I was very grateful for, and grateful that unlike many reports we have to read, that you gave a breakdown of all the different abbreviations right at the beginning. So thank you so much for that. That was much appreciated for this report and the previous one. But as I say, there were just a few things that I felt unclear about.
Would you like me to respond to each of those?
If you could.
Yeah. So the one where Chesterfield were in the top 8 in the country, that refers to the CQC maternity survey. Yeah. So that's completed by women giving birth in February of each year, and it's reported back to the Trust later in the year. So there are several, obviously, lots of questions within that about experience. A lot of it is about personalisation, informed choice, how they felt they were cared for, if they felt safe, etc. That information is available publicly. They are publicly available documents. So for Chesterfield, as I say, twice, 2 years running, they've come in the top 8 in the country, which has been recognised. For UHDB, when it's similar, I'm just saying the results that they report, that service users reported in 2020, I'm going to get my years wrong now, 22 were similar to 23, or whichever, because we're obviously a year behind, aren't we? Yeah, 22 were similar to 23. So that's what I meant by that, so apologies if that wasn't clear from the paper. With fetal monitoring training, that was one of the things that came up through the CQC report, that it wasn't consistent. So yes, you're right, it is midwives, and all midwives and doctors should be trained and are trained in fetal monitoring. But I think it was the reporting that wasn't, it didn't provide the evidence required for UHDB to prove that their staff were trained to a consistent and appropriate level and met the competency required. So they've put in a much more robust system now, where they can evidence that every member of staff has gone through that training to the national standard, they've met the competency, and they do have to repeat that training until competency is met. So it consists of face-to-face training and a competency package. And to meet the maternity incentive scheme standard, they have to have at least 90% of all staff groups trained. So that's why that was sort of highlighted as a concern at the time. But like I say, improvements have been made and they have met the 90% for all staff members. There is a deficit of 10% because that accounts for things like sickness and maternity leave, sometimes staff rotation, and it's just missing out those deadlines for that. Signposting, then it is regarding making sure that the women give birth in the unit which is appropriate for their needs. So for QHB, for instance, they haven't got a fetal monitoring unit, they haven't got the same level of neonatal unit, so the women then might be forwarded to RDH, to attend there instead, so that they can get the level of care that they need at the time, and it doesn't then involve transfer potentially at an inappropriate time when the baby's been born or something. And the open door policy, that's because, again, it was recognised through CQC that sometimes women weren't being seen in a timely manner, and the ones most affected were often the non-English speaking women. We're also seeing complaints come through and some incidents come through with triage, and the women weren't seen quick enough or in a timely fashion through triage. So by offering an open door policy, it means that anyone can walk in to triage and be seen, and it is particularly aimed at the non-English speaking because of the difficulties. Obviously, again, comes back to your point, Councillor, around phones, that you've got to speak on a phone, you might not have English as a first language, that might be difficult. So it's to pick up on that, and they are finding that that is successful, but it is a recent change, so they haven't got data available to share with that as yet.
Thank you. Could I ask another couple of questions? Sorry. The other thing, again, which surprised me was this, well, half surprised me, I suppose, the whole issue around perinatal pelvic floor health. I say half surprised me because in recent years I have in the recent times worked in general practice and said to women, oh, and you will have been taught to do... Sorry.
Councillor Ashby, sorry, if you don't face the mic, sorry,
I know. I've said to women, oh, and you will have been taught to do your pelvic floor exercises. And on too many occasions for me to think, oh, it was just that one person, people have said, nobody spoke to me about pelvic floor exercises after I had my baby. So I was beginning to question anyway whether it is the norm to teach women that they need to do pelvic floor exercises after giving birth, or whether that has stopped happening as a routine.
I think it should happen, and I think we have probably taken our eye off the ball on that across the profession, and I think that involves primary care as well as secondary care. So I think that's where this was highlighted from a national perspective, that the service should be implemented. Having said that, information and education are key points, but it's one of those, the trusts are trying to implement it now, but it takes time because of identifying staff availability, and funding is always an issue. So I think it has been a bit behind the mark, but we are now moving at pace to try and get the service implemented this year. Chesterfield have got a go-live date for theirs of May the 1st. They're already improving their education for women and staff, particularly in relation to pelvic floor, but also when they're identified as being at risk or have suffered harm through perineal injury, and the UHDB service is to be implemented by September.
So do I take it then that it is not, you know, back in the day when I had my children, when I worked in midwifery, it was the norm that the midwife, who was seeing the patient in hospital while they were still there, would give the patient information, written information about pelvic floor exercises, and would, you know, emphasize the need to get on with doing them. So has that completely stopped then? Because, you know, black and white, I can remember, I probably kept it for years, and that's why I remember, just a simple sheet of paper with pelvic floor exercises, isn't that costly?
It hasn't completely stopped, but I think we've just taken our eye off the ball, and it's not a priority, shall we say, or hasn't been probably as much as it should have been. Written documentation is out there, written information, but that isn't always appropriate or suitable for some people. And I think given the competing priorities of maternity services, as I say, it probably has slipped down the list.
Thank you, Chair, and thank you, councillors, for tolerating me coming in again. But I think, so I've got a couple of points. So one point, I have a couple of points separate to Councillor Ashby's, but following on from Councillor Ashby's latter point, when I last visited the hospital as a cabinet member, I was told that women are now sent home routinely 6 hours after giving birth. And I would suggest, I'm not, as somebody who actually had one of her children at home, oversharing, I know, but I couldn't wait to get out the first time. I went home before 6 hours. You know, some people don't want to be there, but I would suggest that for many people, particularly those in need of the most support, 6 hours is not enough to ensure that they're starting to breastfeed, that they do know about pelvic floor exercises. I know we do have health visitors, so it's not just the hospital clearly, but I think maybe perhaps, arguably, I asked the question, I suppose, some of these issues may be coming from the fact that within 6 hours of giving birth, women are going home, and, you know, if it's their second or third, fourth child, are thrust within a family situation where demands are being made upon them, not just of the newborn. So that's just a reflection, really. I think the other point I'd like to make is that I welcome the report. We had a report to the Scrutiny Board a couple of years ago when the difficulties had been highlighted particularly in Derby, and I was the chair then of this board, and I can see that certainly statistically it looks as if there have been many improvements, and I very much welcome that, and everybody should, because the scenario before seemed very concerning. I suppose, and so if I understand the table you've put on page, I don't have any pagination numbers on my print off, but it's table 1, that looks as if at the Chesterfield Royal and the Royal Derby, no, the UHDB, that it looks as if stillbirth and neonatal death rates, each one is a tragedy, of course, but it looks as if the rates in Derby are now below the national average. Is that correct? So that's very good, because previously it was high. But my question is, there are 2 points. First of all, it would be interesting, nevertheless, to see, given the last report and the problems we know that black women in particular experience in giving birth in hospitals, it'd be interesting to know what is the breakdown, the ethnic breakdown of those stats that we already have, acknowledging that they're looking very good now, or they're looking quite good because they're much far below national figures, but still it would be interesting to have that breakdown by ethnicity. And secondly, the colleague sitting behind you, the young fellow from Public Health, sorry for bringing you in, recently gave a report to the Health and Wellbeing Board on infant mortality in Derby, which is running higher, perturbingly higher than the national average. And so this is a question to both of you. Forgive me if this is not an appropriate, Chair, but I'm wondering, because at the time, and I didn't ask this in the Health and Wellbeing Board, but I wondered to what extent some of those figures for infant mortality were being affected by the higher than national average, I can only call it death rates, sadly, among babies at the Royal Derby. And it's a very harsh question to ask. And of course, what I don't know is, off the top of my head, without that report in with me, whether the figures that you were quoting relate to the same period of time that we were seeing such high problems, such high-level problems at the Royal Derby? Thank you.
I'll come in first. So I'm actually working with Sean on some of the infant mortality work because they do overlap. So infant mortality will include the neonatal death rates quoted. I think we will have been looking at the same period of time for the national data, but what we recognise locally is that our rates are now improving, but that won't be reflected in national data because we always work sort of 2 years behind because of the process of getting the data cleansed and then shared. So when you look at Embrace data, it's usually two years behind. So we are now confident that our data is improving and the rates are reducing, which obviously is good news, but we are working together across maternity and other stakeholders linking in with Sean to look at causes of infant mortality and where we can improve services really to then improve the outcomes.
So forgive me, just if I may, Chair, just very quickly. So just for my clarity, I'm sure if it's clear to everybody else, could we make the assumption then, without having the proof, that because the stillbirth and neonatal death rates have reduced at the hospital, we might thereby assume that some of the infant mortality rates that we were looking at, which are slightly, obviously there's a delay, that they may have likewise have reduced slightly, all other things being equal?
I think hopefully we can be cautiously optimistic about that. I think the thing to be cautious about is just that the latest national data that's now 2 years old goes through various cleaning processes and is reviewed in various ways, whereas the data that comes through more recently from the trusts doesn't go through those processes. So we'll have to see if that cleansing of the data, and I'm not entirely sure what the data owners do to do the cleansing, but if that makes, there's potentially a bit of difference that we might see moving forward. If that doesn't change too much, then we can be hopeful that that infant mortality rate has come down, but I wouldn't want to commit to that before we see those updates. Thank you.
Has anyone got any further questions? Okay, I'd like to ask a question, please.
Forgive me, Chair.
Sure.
I know, just very quickly. Okay. So do we have the breakdown by ethnic group for those figures then?
It is available within the trust. So they do know in relation to the mortality. We are working within the ICB to develop a health inequalities dashboard, which will provide the ability to break it down into ethnicity and other demographics so that we can see more accurately what affects mortality along with other outcomes, including things, as we've already mentioned, about perineal injury or postpartum hemorrhage, anything.
So will we see those statistics quite soon then, please?
The health inequalities dashboard is being worked on. Within the trust, they do have some of that data. Relating to ethnicity, they do have that.
And will we see it then, please?
It can be seen in a... you mean following this meeting or in a future report?
Well, according to the Chair.
Yeah, after this meeting, if you can circulate that information, that'd be great. Any further questions, Councillor? No? I'd just like to ask a question. On Wednesday, the 18th of January 2023, we had a full council meeting and a motion was passed that was proposed by Councillor Ingle. I'll just read the motion out, which was, before a newborn baby is allowed to leave the hospital and go home, their parents must watch a 4-minute video about not shaking babies. Yet, they do not have any training on performing CPR on babies. This council resolved to resign to Derby and Burton Hospital Trust and ask them to introduce this measure and write to the Secretary of State for Health and ask them to introduce this measure across all hospitals. So my question is this now in place?
Yes, you're referring to Rowan's rule, I believe, and that was developed with Rowan's mum, Rachel Pepper, in collaboration with UHDB, Derby Family Hubs and Derbyshire Maternity and Neonatal Voices. The promotion of it is obviously the video, which will be shared with parents. I'll spit my words out. So yes, UHDB have adopted that. It has been shared regionally, and we're hoping it's going to be shared nationally, and Chesterfield Hospital have adopted that. It's not shown routinely at the minute, but it is going to be incorporated into the video, but all parents are given access to the QR code and the information on how to access the videos.
Thank you. Moving on to recommendations 2.1 and 2.2. Would anyone like to put any recommendations forward? No. So to consider the update report on maternity services in Derbyshire, April 2024, February 2025, to make any further comments and recommendation follow discussions on report received. So thank you for the report. And I think we can move on to the next item, so item 7. So item 7, which is suicide prevention in Derby.
Thank you, Chair. So I'm Alan Reid, Consultant in Public Health here at Derby City Council. I was supposed to be joined today by ICB colleague B. Grobert, who's the Associate Director for Mental Health in the Integrated Care Board. I understand that the request to the scrutiny panel came to the ICB, and it follows on from an item that myself and an ICB colleague, Jennifer Stoddard, presented on men's mental health about 6 months ago, where the ask was to bring a more general update on suicide prevention. So I'm happy to talk through that, but if there's any items regarding that are ICB particular focus, we may want to take those questions to that, but I'll do my best. I'd like to just start by acknowledging that obviously every death by suicide and every suicide attempt is a real tragedy and could be prevented. We have to acknowledge that individuals here may have in some way been affected by suicide, and it's an upsetting subject. So if that is the case, please do reach out afterwards. I'll be at the stay around at the end. There's support that I can signpost you to in terms of the Tomorrow Project, who are active in Derby, obviously the Samaritans, and survivors of bereavement by suicide. So please reach out if this is in any form, any way upsetting to you and you have personal experience. So that said, I've given a paper submission to this and just some slides here that I'll just take you through. So just based on that, given that every suicide is a tragedy that could be prevented, it goes really without saying that effective suicide prevention requires a whole system approach. And I've just quoted some of the most up-to-date latest figures for suicide rates in Derby, comparing that to the national average. Suicide rates or suicide data, there's two forms of the data. There's routine data that's captured by the Office of National Statistics, and that's what's presented there. Due to relatively low numbers, thankfully, the data is pooled in 3 years, which can give some wide fluctuations. You can see that with Derby there, 2005 to 2007, that 3-year pooled data. There was a rise that brought us into the red, so significantly different from the national average. Thankfully, that went down to track with the national average. Then in 2014, 2015, went down into the green. You can see, though, that since 2017, there has been a steady rise. Now, whether that's real in terms of bearing in mind the small numbers and the pooled nature of the data, that you can get that fluctuation, but it is something we're interested in. It still remains statistically similar to the national average, though, but it's certainly something to watch. If you think about the impact of the pandemic on mental health, the cost of living crisis, you can see that perhaps that's something that we should be concerned about or taking note of. But basically what we can say is suicide rate in Derby is similar to the English average. Between that latest pooled 3-year pool period, 2021 to 2023, there were 77 deaths in the city. And you can see that the majority of them, 72%, were males. So that's 55, and 22 that's 28%, were in females. What we know about that difference between male suicide and self-harm difference from females is that attempts by males have more success or an outcome in terms of completed suicide, whereas for females there'll be more instances of self-harm but less actual completed suicides. Just breaking that data down a bit more, and where the other bit of information comes from, I talked about the routine data from the Office of National Statistics. Another source of data is the real-time surveillance data. That's heavily restricted and delves in a bit more in detail. And it's restricted basically because of the low numbers, the fact that it breaks down a bit more so it's potentially identifiable. And that's only given out to people or access to people who are working and can demonstrably in suicide prevention in local government settings. But that can break down figures a bit more. But we can find out from that data there that 73% of over the last 10 years, 2009 to 2019, who died by suicide were not in contact with mental health services. And that doesn't mean to say they weren't in contact with the GP in primary care, but mental health services in the 12 months before their deaths, which is really quite something to consider regarding of suicide ideology and the things that drive and the determinants that make people consider suicide. We know that most deaths by suicide occur in people's homes, about a third occur in public locations. And as I said, when we talked about that rise, we do recognise that there's been particular risks of late in terms of cost of living and social determinants of health, such as housing, poverty, employment and education. Next slide, please. Thank you. The National Suicide Prevention Strategy was recently updated in 2023, and it's a 5-year strategy, 23 to 28, and it's identified particular risk groups and risk factors, which it recommends that targeted action is done at a local level. So thinking about some of the key risk groups, children, young people, and the impact of social media, and you've heard some perhaps high-profile cases in the media regarding that. Middle-aged men, as we said, the vast majority of completed suicides in Derby City, and of course that mirrors elsewhere, are in men. Usually the most common cause of death for men under the age of 40, but also there's a period where it then rises again in middle-aged men. People who have a history of self-harming, people in contact with mental health services, even though, albeit what we said about the percentage of suicide deaths where the person hasn't been in contact with, but nevertheless, people in contact with the justice system, people who have autism and other neurodiversities as well are recognised as a particularly emerging risk factor, and pregnant women and new mothers. So that's some of the key groups that we're interested in. Some of the key risk factors on the next slide there. People who have long-term conditions, physical illness and the impact that has on mental health. We talked about the cost of living crisis, so poverty and economic adversity. Gambling is another recognised risk as well for self-harm and suicide. Substance misuse, another emerging one now, and again that's had quite a lot of press and media attention of late, is the influence of domestic abuse on suicide attempts for women in particular, but not limited to. And social isolation and loneliness is another emerging risk factor as well. So these are the kind of areas that the work in Derby City, and I'll explain how we work around the suicide prevention agenda in the next slide, but these are the kind of focus areas we're looking at. So we'll go into the next slide, please. Sorry, this is a bit difficult to see, but I'll talk you through. So basically, it's just outlining the governance and the structure. So we have a really well-attended group in Derby and Derbyshire County Council. So just to note that around the suicide and much of the mental health agenda, we work alongside our ICB colleagues, but we work closely with our county colleagues, and we have the Derby and Derbyshire Self-Harm and Suicide Prevention Forum. We actually met this morning. It's a really thriving group, particularly around something I'll mention later that you've probably all heard about in this Baton of Hope tour that's coming to Derby, which has really energised this agenda. But basically, there's some of the governance there, some of the subgroups that we've got working under this Self-Harm and Suicide Prevention Forum. It's got partners across, as you might expect, from the voluntary sector, primary care, from the ICB, from the provider, hospital trusts, and wider as well. We've got a GP lead who covers Derby City and the county as well, who's very passionate and active in the mental health and suicide prevention agenda space. We report into the Mental Health, Learning Disability and Autism Delivery Board. That's where B from the ICB chairs and leads on that. And we also report into our respective health and wellbeing boards for Derby County and Derby City local authorities. The diagram just on the chart on the left-hand side just shows some of the external groups that this links into, the self-harm and Suicide Prevention Forum, so the Children's Commissioning Board, the Child Death Overview Panel, and other adults, Safeguarding Adult Commissioning Board, the Bereavement Support Subgroup. So you can see it's a really, what I'm demonstrating here, it's a really well-connected group with membership, as I said, a really thriving and vibrant membership. So go into the next slide, please. Just some of the strategic priorities now. This is very much in time at the moment. I've talked about the Baton of Hope, which I'll mention a bit later. But our own suicide prevention strategy, again, we've got a joint one between Derby City and the Council. That is due to be refreshed next year. So we've just recently formed a working group for that taken forward. But we're still working to the strategic priorities from the last 3-year strategy from 2022 to 2025. And basically the strategic priorities were 8 of them in total. You can see they're reducing the risk of self-harm in known high-risk groups, and I mentioned some of them before. Tailor the approaches to improve mental health and emotional well-being in specific groups. So again, recognising that the risk of suicide is not distributed equally amongst the population. Reducing access to the means of suicide, and we've been doing some focused work over the last couple of years with our structures team, looking at access to the means of suicide, in particular around bridges and other council structures. Providing better information to support those exposed to self-harm or bereaved by suicide. So this really recognises that each suicide affects on average over 150 people in the community, not just the immediate family and friends, but also the wider community, people, work colleagues, etc. And it can have a real impact, as I mentioned at the start of that and of my presentation. So it's really important to give that post-pension support to the community. Support to the media in delivering, and obviously with social media, it's even more important that reports and items regarding suicide and self-harm are reported sensitively, and there's guidance on that for that reporting and how we should respond to social media messages on that from the public. Support research and data collection and monitoring. It's always important. I mentioned the 2 main sources of data. Again, as I said, given the relatively low numbers, we've got to be careful with how that data is reported, but it's always good to have more real-time surveillance so we can take action on where there's clusters of suicide cases, which are really important so we can target interventions. Building the confidence of local communities to prevent and respond to self-harm and suicide. And this is where the Baton of Hope tour is really going to come into the fore. This whole ethos is to raise awareness of mental health and to get everyone talking about suicide and suicide prevention, and to really give that embodiment of hope as the name suggests, but by a really symbolic way of carrying the baton of hope. Utilising a population health approach and addressing health inequalities, which I've alluded to as well. We know that the risks for suicide are distributed unequally in our communities. The next slide, please. So just an overview of what's been done, and I think the report just covers this. I'll just pick out some of the highlights there. Obviously, our online offer is covered largely by the Derby and Derbyshire Emotional Health and Wellbeing website, which has a section dedicated to suicide and self-harm prevention with signposting to support and advice for that. In the community, bearing in mind that 73% of suicides occur in men, there are some active men's health groups, mental health, Mentel, Andy's Man Club, the Derby Community Trust do a lot of work with men's health. So and the report goes into some of the initiatives that's happening there, men's sheds. So basically a lot of community support for men. There's the Mental Health and Suicide Prevention Outreach Project, and that's commissioned by the ICB and delivered by Derbyshire Community Healthcare Trust to reach out to communities and also to provide training to health and social care staff, and that's bolstered by our own training offer for people working in Derby City for suicide prevention and mental health first aid training. So there's quite a heavy training support offer. Another example is of training that's been going on in Derby is the Zero Suicide Alliance, providing training for taxi drivers in the city, which is currently ongoing and has been in place for a number of years. There's suicide prevention training within primary care, with the recruitment and upskilling of suicide prevention champions in our primary care networks, and with my own role spanning mental health and suicide prevention and the co-chair of the Derby Place Partnership Board, I've been able to look to strengthen that and get the Place Board more involved in that. And again, the Baton of Hope coming to Derby has been a real opportunity to build those networks. So next slide, please. Some of the other aspects there, just very quickly, again, an ICV, Integrated Care Board service is the Mental Health Crisis Service, the crisis cafes, the safe havens, and the home treatment support for people who are going through crisis moments and periods where they may be at higher risk of suicide. Local area coordinators, Community Action Derby, as I mentioned, the Men's Shed initiative. These are spaces in the community where men can come together. Derby City Council, we've commissioned, I said, a mental health first aid training. Just in terms of numbers, 140 local people become qualified mental health first aid trainers last year. That includes suicide prevention and how to talk and raise the subject and deal with suicide. As I mentioned, the Public Health and Structures team, we've been developing policy and collaborative working over the last couple of years to improve the reporting and sharing of information of suicide and self-harm related incidents involving bridges and council structures. We have a much more joined up and cohesive way of working and how we report, and how the structures team then use that information to go out and do risk assessment of sites, whether that's to add signage or any other structural work that needs to be done. Next slide. So the Baton of Hope, just finally, I wanted to talk about that. So the Baton, as I mentioned before, Baton of Hope is a charity that's dedicated to mental health awareness and to make sure that suicide prevention is on everyone's agenda, it's everyone's business. It's in its second tour this year. The first one was 2023, so 2 years ago, where it visited 25 cities and towns on a daily basis, which I think from learning from what we heard from Luke and from Claire from the Baton of Hope tour, who presented incidentally to Cabinet CLT last week. And I think you were there, Councillor Martin. I think it was really well received. So there's been a lot of learning. It was a very successful tour with a lot of media attention. Derby successfully bid to be on the tour, and the torch is coming to Derby and parts of South Derbyshire, where it starts on Saturday the 13th of September. You can see the tour mapped out there. I won't go into. It starts at Elveston Castle with the motorbikers, mental health motorbikers for suicide prevention carrying the torch. It's coming round up London Road to the Nightingale Hospital, to Alstrom, to the EMR in Derby Station, to the university, to the football ground, Pride Park, to the cricket ground. So a real, to finish at Cathedral Green. It's been sailed down the river as well. So it's going to be an absolutely fantastic day, and it's really a fantastic opportunity to bring the suicide prevention agenda into Derby, into the spotlight. And I have to say, you know, I've been supporting where I can. I mentioned the names of my colleagues, Luke Oldham, who's suicide prevention lead at Derbyshire County Council, and Claire Gorham, who is from the Baton of Hope Tour charity herself. They've been really supporting this and working great guns. There's a website, there's Facebook. We've got all the information out to you for how you can want to get involved in that. But it's a real opportunity, and it just fits nicely with a refresh of our strategy, the legacy that the tour is going to bring, and the opportunities for that. So I think it's the last slide. Yeah. Yep, just another map, why not? You can see the mental health motorbikers, the ride of the baton from Elveston Castle to the university. We've got a whole team of baton bearers from the public, people who have had personal experience or have been affected in some form or other by suicide, who are carrying the baton in 300-metre stages. So you can see the stops on that. So please do contact me or have a look for it, the Baton of Hope. If you need any more information, I'll be happy to chat to you and link you in. And just again to Councillor Martin, you've been very helpful in supporting that as well. So I know you'll be a champion for that as well. Next slide. Thank you very much for your attention. Happy to answer any questions.
Thank you for going through the report and the presentation and explaining what's happening and what will be happening in the future. Much appreciated. I'd like to open up to the floor if anyone's got any questions. Councillor Hudson.
No, thank you for that on this awkward topic of conversation. Right, we're looking at the numbers, and you say there's not much variance from year to year, statistical variance.
Yeah.
What kind of numbers are we actually looking at in reality rather than per 100,000 people?
So the numbers are there in the second point there, so you can see the whole numbers. So that reporting period 2021 to 2023, that's 77 deaths in the city. So that's 55 were in males, 22 were in females. So obviously it takes a rate per 100,000 to make it comparable, but that's the whole numbers there. So 77 deaths in that 3-year reporting period.
And is there much variance across the different socio-economic groups, what you find in the locality?
Again, you've got to look carefully at that because it comes under the real-time surveillance, so we can. But yes, the bottom line is you would expect to see it that there's higher rates. Not always. Sometimes there are some variation, but generally, yes, you would find higher rates within lower socio-economic groups.
I was just about to say, is the pattern what I'd expect to see?
Yeah,
thank you.
Exactly.
Thank you for the report. It's good to see all that's being done. And obviously the Baton of Hope is good news. At the beginning of that slide about the Baton of Hope, you mentioned a refresh of the joint city and county self-harm and suicide prevention strategy. And we know that people who self-harm are at greater risk of committing suicide. But the numbers who self-harm are, in my perspective, seem to be very large. And that's obviously a group of people who do have mental health problems. Can we ever make any impact on suicide prevention and certainly self-harm prevention until there's enough investment in mental health?
Yeah, absolutely. Yeah, I agree.
What was the answer?
Yeah, I think it needs that investment. I think it needs that support.
Thank you, Chair. And I'd like to thank Alan, I mean, you know, for the work that he does in this area. It's one I find difficult, as he knows well. I'm sure many of us do for very personal reasons and for general reasons as well. But I just have a thought, Chair. I don't know if this is appropriate, but I believe there's still some space for some baton bearers. Is that correct?
I believe so, yes.
Yeah.
I wouldn't, I'd always run it past Luke, sorry. I'd run it past Luke first, but yeah, I believe there is.
I think it would be quite nice, Chair, if there was like perhaps it would be nice if we had a baton bearer from every political group in the council. It'd be nice to see that, you know, the engagement from all the groups, if that were something that people wanted to do and was of interest. I mean, obviously everyone's interested, but if it's something people felt able to do and could do, I think it would be nice to get, that all the groups and as many councillors as possible supporting this event, because it's, you know, obviously something that concerns all of us. Thank you.
Yeah, I'm fully on board on that. I think that's a good idea, an excellent idea. Thank you. Councillor Ashby.
Thank you. I was just trying to remember what my question was. Ah, yes, it was about the links with gambling and young men. And not that long ago, we heard in a Health and Wellbeing Board meeting, you know, the school nurses in doing questionnaires in secondary schools are finding children as young as 13 who have been gambling. So as part of that strategy, you know, we do know that some of that cohort of those who've committed suicide, sadly, are young men who've had problems with gambling. Is there going to be any focus on trying to tackle that issue of gambling in schools as an early preventative?
Yeah, absolutely. I mean, when I mentioned the key risk population groups, I mean, they're always there and they've always been known about, but I think they have more of a focus now as the evidence builds up. So gambling, definitely one of them. The effects of domestic abuse, you've heard on the news there where women have been almost coerced into taking their own lives by their partners, and then there's been no action taken against that, where the whole family knows that that's been the case. So domestic abuse is really getting a focus. Neurodiversity and the role of mental health and the risk of self-harm and suicide for that. So these are going to be focused areas in the refresh of the strategy. So I think the strategy will still have the same general message, but it'll have a focused and in particular emphasis on areas. And of course this links in with Robin's Director annual report from last year on gambling harms as well. So it's a good way to just link the two together and get that cohesion between them.
Just looking at the report, it said there is also a Andy Mann's Club group in process of being established. How close is it from being fully functioning and running? I
don't have the exact answer to that. I know it's there. I think it's there's a group. There's the main shed. There's the Andy Club. Is the people are involved and they're in the city, but I don't know if it's fully functional or running there. But I can find out.
Thank you. Any further questions? The only other question I have on here, which is how well are local services collaborating together to prevent suicide? So, like mental health people, or social care, or GPs, police, voluntary people. How well are they working together?
Yeah, it's a good question. As I said, our Derby and Derbyshire Joint Self-Harm and Suicide Prevention Partnership Forum is a really thriving group. As I said, we met this morning. There was about 38 people joined from all over, from primary care, from secondary care, from the voluntary sector, from the various community groups. patient and public involvement from people who have got lived experience of suicide. So it's a really wide area and a good range of stakeholders. So I do think we have got a good, vibrant group of engaged partners around the agenda.
Thank you. Any further notes or questions from the floor? No. Moving on to the recommendation 2.1 and 2.2. So to note the report, and I don't know if we need to add it to a recommendation about Councillor Thornton's idea about passing the baton, or do we need to add that as a recommendation?
Well, I always walk away, honestly, there's something wrong. I always get the actions, don't I? Yes, yeah, I'm happy to do that. I could just, so do you want to find out if there are some places first, Alan?
I'll email Luke tomorrow and I'll copy in Councillor Martin, just say that he knows we're presenting tonight, so I'll say that was one of the recommendations, and
Yeah.
so.
And if you, Chair, and if you think it'd be all right, I could just write to the group leaders and make this suggestion. Would that?
Yeah.
Well, I suppose I don't know. We could, except that well, first of all, I am very wary about writing an email to anybody about this subject without a warning. So, and the other would be that my thought was just to be a representative sample, because obviously the idea is for those, many of us are affected by suicide, but, you know, is that the baton bearers would be people particularly affected by suicide. So, so if that's okay, Richard, I'll probably just contact the group leaders, if that's all right. Is that, yeah? Does that make sense? Is that a good idea? Okay. I mean, but obviously, Richard, if there is a councillor, if there's more than one within a group, then it's obviously, I'm sure that contact Alan, see what space there is.
Yeah,
I'm sure that would be fine. Thank you.
Thank you, Councillor Martin, and thanks for taking that action away. So, yeah, and just moving on to the recommendations, to consider the report and make any further comments. And I'd like to thank you for the presentation and going through the presentation as well.
Thank you, Chair.
So, item 8, Work Programme 2024 and 2025. Again, to note the report, to consider agree the work programme for 2024 to 25. I think we've got quite a lot on the programme already for the October and January and April meeting. Does anyone suggest adding anything else onto the programme at this stage? No.
Sorry, I don't want to add anything to the programme. Looking at the minutes of the last meeting, it spoke about, with the GP workforce report that's due to come back, spoke about wanting the numbers of GPs. But I think what we need is more clarification around the whole GP workforce, because in general practice, there's a lot of people who see patients who could be seen by a GP, but could be seen by an advanced clinical practitioner, advanced nurse practitioner, or maybe a pharmacist or whatever. So I think we need a breakdown of the GP workforce, not just numbers of GPs, because numbers of GPs is only part of the picture. But it specifically in the minutes says numbers of GPs. It talks about workforce, but emphasises that, and I just think it needs to be more wholesome information, really. Thanks.
Thank you. Sorry, is that to come back on one of the future agendas then?
In the minutes for this, from the last meeting, we had a report, which is what put the GP workforce for a future topic on this list for the programme going forward. So we've asked for more information on the GP workforce in the city. And it specifically said numbers of GPs. But what I'm saying is it needs to be broader, if possible, than not just whoever is doing the report. I don't know whether that will fall to Robin or somebody else. That it needs to be broader than just GPs. That's what I'm saying, really.
Thank you. Okay, I think that's everything on the agenda then tonight, and I thank everyone for their attendance. Thank you and good night.